Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
Hello, and welcome to the Health Advocates. I'm Stephen Newmark, Chief Policy Officer at the Global Healthy Living Foundation. Our goal is to help you understand what's happening in the world of healthcare. Last week, President Trump signed a new executive order that could significantly reshape childhood vaccine policy in the United States. The order calls for fewer vaccines to receive a universal recommendation for all children. It encourages greater spacing between vaccinations. It proposes eventually replacing the combined measles, mumps, and rubella vaccine, or the MMR vaccine, with 3 separate vaccinations, and it asks states to reconsider some of their school vaccination requirements. That's a lot, and if you're a parent trying to figure out whether your child's vaccination schedule suddenly changed, you have a good reason to feel confused. So today we're going to get into each of the 3 questions and figure out what exactly happened. The 3 questions, of course, are: what exactly did the presidential order say? What does it change right now? And perhaps most importantly, what does the medical evidence say about the recommendations families have relied on for decades? Let's start with the policy. President Trump signed Executive Order 14420 on August 10th. The administration calls its new framework the gold standard childhood vaccine recommendations. Whether it's actually the gold standard, you can be the judge of. Under the order, the federal government places childhood immunizations into several categories. The first category includes vaccines recommended for all children. That group protects against 11 diseases, including measles, mumps, rubella, polio, pertussis, tetanus, diphtheria, certain forms of bacterial meningitis and pneumonia, HPV, and chickenpox. Other immunizations move into either a higher risk category or something called shared clinical decision-making. That second group includes vaccines or immunizations involving hepatitis A, hepatitis B, rotavirus, meningococcal disease, influenza, COVID-19, RSV, and dengue, depending on the vaccine and the child's circumstances. Now, shared clinical decision-making sounds fairly innocuous, but this is something we've discussed before on this program. It sounds innocuous because, after all, shouldn't patients and doctors make medical decisions together? Well, of course they should. But in vaccine policy, the phrase has a very specific meaning. It distinguishes a vaccine that is routinely recommended for an entire age group from one that doctors and patients should consider based on individual circumstances. That distinction can influence how clinicians discuss vaccinations, how healthcare systems send reminders, how vaccine programs operate, and ultimately, whether people receive a vaccine at all. The executive order goes even further. It says that to the maximum extent feasible, childhood vaccines should take place during separate medical visits rather than several vaccines occurring during the same appointment. And it calls for eventually separating the MMR vaccine into individual measles, mumps, and rubella shots once such products become available in the United States. They're not currently available. Finally, the order gives the Department of Health and Human Services 90 days to develop plans involving vaccine timing, sequencing, single disease vaccines, safety monitoring, and additional research. It also encourages states to reconsider vaccination requirements for schools and other settings. So this is more than just a press release, but that does not mean that every child's vaccination schedule will change overnight, and that distinction matters. Let's talk about what this order does not do. First, it does not automatically change your state's school vaccination requirements. States establish those requirements. There's no single federal law that determines which vaccinations children should receive to attend school. The executive order encourages states to reconsider their rules. It also directs federal agencies to support legal challenges involving exemptions. But an executive order cannot simply rewrite every state's vaccination laws. If your state required certain vaccinations for school before August 10th, you should not assume that those requirements disappeared on August 11th. Second, the order does not remove existing vaccines from pharmacy or pediatrician shelves, and it does not revoke FDA approval for vaccines that have already been approved. Third, it does not suddenly create separate MMR vaccines. Those products do not currently exist, as I mentioned, as individually licensed and marketed vaccines in the United States. Manufacturers phased out the previous single disease products years ago. So if you hear that the government has, quote, split up MMR, that has simply not happened. The executive order simply says that the government should work toward making individual vaccines available and should favor them once they become available. Developing, manufacturing, studying, licensing, distributing, and incorporating new vaccine products involves considerably more than just taking an existing vaccine and dividing it into 3 syringes. The order also did not emerge out of nowhere. In December of 2025, President Trump directed health officials to compare the U.S. childhood vaccine schedule with schedules of other developed countries. In January, CDC leadership announced a revised framework that reduced the number of vaccines routinely recommended for all children and moved others into different categories. That generated an immediate conflict with major medical organizations. The American Academy of Pediatrics continued to recommend its own childhood immunization schedule, which includes protection against 18 serious diseases. Then, in March, a federal judge blocked implementation of the new federal schedule while litigation continued. And now we have the August 10th order, which seeks to move to an entirely new framework when it comes to childhood vaccinations. That history background matters because patients now face something unusual. For many years, parents could look to their pediatrician, the American Academy of Pediatrics, and federal public health agencies and generally receive the same vaccination recommendation. Today, those sources may tell them different things. The fragmentation itself creates a public health problem. One of the most significant recommendations in this new executive order involves the timing of vaccines. The order says childhood immunization should occur during separate medical visits to the maximum extent feasible. That may sound cautious, but let's be realistic about this. Some parents may understandably wonder whether receiving several vaccines during one appointment places too much of a strain on a child's immune system. In reality, the evidence does not show that spreading routine vaccines across several visits makes vaccinations safer. Further, the idea of asking parents and children to come back to a doctor's office multiple times will decrease the amount of opportunity you have to receive vaccines, thus likely creating a situation where less folks are becoming vaccinated, which obviously has an attendant effect on the immunocompromised community. Parents work, kids get sick, transportation becomes difficult, appointments get canceled, families move, insurance changes. Every additional visit creates another opportunity for a vaccination to get delayed or missed altogether. CDC's own immunization guidance has long recognized that simultaneous vaccination increases the likelihood that a person receives appropriate protection at the appropriate age. And remember what spacing actually means. If a child receives one vaccine this month and another vaccine several months later, that child spends those extra months without protection against the second disease. So the question should not simply be, can we spread these vaccines out? Yeah, of course we can. The better question is, does spreading them out make our society healthier? The evidence has not been established that it does, and in fact, delaying protection carries its own risks. That brings us to the proposal to separate the measles, mumps, and rubella vaccination. The administration wants manufacturers to eventually offer 3 individual vaccines instead of relying on the combined MMR shot. But we already have decades of experience with MMR. The vaccine provides very strong protection against measles. 1 dose produces immunity in about 93% of recipients. 2 doses increases protections to approximately 97%. And the timing of this proposal deserves attention. The United States is experiencing its highest level of measles activity in 35 years. That makes this a particularly consequential moment to introduce uncertainty around one of our most important childhood vaccines. Measles is not simply a rash and a few uncomfortable days at home. It can cause pneumonia, hospitalization, inflammation of the brain, permanent complications, and death. It's also extraordinarily contagious. And this matters enormously for people living with certain chronic illnesses. Some patients who take significant immune-suppressing medications cannot safely receive live vaccines such as MMR. They rely in part on everyone around them having protection. When enough people receive a vaccination, a virus has fewer opportunities to find someone vulnerable. That is why vaccination involves both individual and community health. For an immunocompromised child, the vaccination decision another family makes can affect his or her risk too. What about the argument that other countries give fewer vaccines? The administration has emphasized that the United States recommends more childhood vaccines than many peer countries. Well, let's put that into context. Different countries do have different vaccine schedules, but counting the number of vaccines on 2 schedules does not tell us which is better. Countries differ when it comes to disease prevalence. They differ in regards to their particular healthcare systems, access to medical care, vaccine uptake, surveillance, population characteristics, school policies, and how governments deliver preventive care services. The relevant scientific question is not necessarily, does Denmark recommend fewer vaccines than the United States? The relevant question is, would adopting Denmark's schedule produce better health outcomes for the United States? Those are different questions. The American Academy of Pediatrics says it has seen no new scientific evidence that justifies these major changes in childhood immunization recommendations. The organization continues to recommend its 2026 schedule, which protects children and the population at large against 18 serious diseases. That does not mean vaccine recommendations should never change. They should when science evolves, when disease patterns evolve, when new vaccines become available. A good vaccination schedule should evolve with the evidence. But changing the schedule because new evidence demonstrates a better approach differs from changing it because another country has fewer rows on its chart. There's another part of this debate that also deserves attention. The administration argues that public health institutions have lost trust and that giving parents more choice may help rebuild it. The loss of trust is real. People emerged from the COVID-19 pandemic with very different experiences and very different attitudes towards public health. Some people believe officials communicated too confidently when evidence remained uncertain. Some people believe political leaders interfered too much with the science. Others believe government placed too many restrictions on individual choice. Public health officials should take those concerns seriously. But rebuilding trust requires more than telling people that every side has an equally strong scientific argument. Sometimes the evidence does point overwhelmingly in one direction. Multiple vaccines at the same site have a very strong safety record. The MMR vaccine works. Vaccines do not cause autism, and vaccine-preventable diseases can cause serious harm. Trust requires telling people those things clearly while still allowing them to ask questions. It also means that acknowledging genuine uncertainty when it exists. There is no contradiction between respecting patients and giving them strong medical recommendations. We should be able to do both. At the Health Advocates, we spend a lot of time talking about people who live with chronic conditions. So why should this community pay particular attention to childhood vaccine policy? Because changes in vaccination rates do not affect everyone equally. Consider someone receiving chemotherapy, or a child taking immune-suppressing medication for an autoimmune condition, or an organ transplant recipient. For these patients, preventing infectious disease often requires more than making an individual choice. They depend on family members, classmates, and others in the community, reducing transmission around them. That is one of the reasons declining vaccination rates concern public health experts. The person who faces the greatest consequences from an outbreak may have very little control over whether that outbreak occurs. And there's another issue. Conflicting recommendations create additional burdens for patients who already navigate a complicated medical landscape. If the CDC says one thing, the American Academy of Pediatrics says another, a school requirement says something else, an insurance company interprets federal guidance in yet another way, families have to sort through the confusion themselves. For people managing complex health conditions, healthcare already requires enough homework. We should make credible preventive guidance easier to understand, not harder. So where does this leave families? Where does this leave the public at large? First, do not assume that last week's executive order requires you to change an existing vaccination plan. Talk with your local pediatrician, talk with your local doctor, or another trusted healthcare provider. Second, remember that the American Academy of Pediatrics continues to recommend its evidence-based 2026 childhood vaccination schedule. That schedule has not disappeared because the White House issued a different recommendation. Third, if you or your child has a chronic medical condition or take an immune-suppressing medication, discuss vaccinations with the clinicians who understand that condition. Certain vaccines may require different timing or may not be appropriate for certain immunocompromised patients. That makes individualized medical guidance particularly important. If your concern involves school requirements, check your state or local health department. And finally, ask questions. Good medicine should withstand good questions. The debate over vaccines has become intensely political, but viruses and bacteria do not know whether someone votes Republican, Democrat, Independent, or doesn't vote at all. Measles does not check party registration before spreading through a classroom. The flu doesn't care which cable news network you watch. And an immunocompromised patient does not become less vulnerable because the country is arguing about public health. Families do not need to wait for those debates to resolve before protecting their public health. We already know a great deal about vaccines. We know that the existing childhood vaccines have prevented enormous amounts of disease, disability, hospitalization, and death. Parents deserve accurate information. They deserve the opportunity to ask questions, and they deserve recommendations rooted in evidence rather than confusion. Thanks for listening to The Health Advocates, a podcast that breaks down major health news of the week to help you make sense of it all. If you found this episode helpful, please like and subscribe and leave a comment down below. And be sure to follow us wherever you get your podcasts. You can find all of GHLF's podcasts at ghlf.org/listen. I'm Stephen Newmark. We'll see you next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.